Understanding and addressing individual and group behavior is essential in order for teams to meet their goals and serve their patients. The AHA's Physician Alliance has interviewed several clinician leaders to understand how hospital leaders can make medicine safer, kinder, and more reliable through promoting professionalism and accountability. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. In this episode, Elisa Arespacochaga, Vice President of AHA's Physician Alliance, speaks with Patricia Sullivan, Chief Quality Officer at Penn Medicine in Philadelphia, Pennsylvania.
Welcome to another podcast in the AHA's ongoing series where we focus on important issues facing clinician leaders. I'm Elisa Arespacochaga, Vice President of AHA's Physician Alliance. And today I'm joined by Patricia Sullivan, Chief Quality Officer at Penn Medicine in Philadelphia. Today we're talking about how hospital leaders can make medicine kinder, safer, and more reliable through promoting professionalism and accountability. To get started, Pat, tell me a little bit about yourself and your experience.
Well, I'm a clinical nurse by training. I have a health services research background with a PhD in health policy and management. And I've been doing a lot of work on the change management side in organizations for probably maybe 20 years now in different organizations. I came to Penn in 2004, and there was a relatively new CEO. His name was Ralph Muller, and he told me that he likes to hire people who somebody tells him has talent. He gives them things to do, and he sees where they best fit in. And it asked if I was up for that ambiguity, then he would like to hire me. And so that sounded very good to me. And so we started to work through a couple of different projects. But about a year into his tenure or at Penn, we had some, significant issues with our malpractice expense. And so what he said was, we can sit around and wait for tort reform in Pennsylvania, or we can do something ourselves, and asked me to take a look at malpractice and what we might do as an organization. So I went out and did some research, talked to internal and external people, looked at our data, and then we came up with a plan around clinical risk mitigation. And one of our first actions was to evaluate the Vanderbilt Center for Patient and Professional Advocacy and look at their PARS program, which stands for Patient Advocacy Reporting System. So that was my early experience, and we've been working with Vanderbilt ever since then. We do a lot of other things as well. There's rarely a silver bullet, but that is my initial experience with working on how we got started at Penn around professionalism.
Great. So tell me a little bit about how professionalism works at Penn. How does this professional accountability work that you've done in partnership with the Vanderbilt team really play out at Penn?
First, let me say that I've been working in quality at the same time. I started working on malpractice first, but quickly realized that, if you need a framework, better outcomes and better risk mitigation will lower malpractice, then we've been doing both. And so we've done a lot of other things like creating local accountability units, developing a blueprint for quality and patient safety that had a big focus on professionalism, et cetera. So that's some of the infrastructure that we've put in place at Penn to sort of surround our work on professionalism. It really is a foundational issue for us in terms of how do we achieve quality, patient safety, and staff engagement. Having said that, at Penn, the sort of essential elements of how professionalism works, in my mind, really centers around physician and staff engagement, a culture of team-based care, and a willingness to speak up and out in a constructive way to identify potentially unsafe conditions, whether they be for patients or a fellow staff member. I think another essential component of what we've tried to build in defining professionalism is also a willingness to be part of a solution, as well as understanding the importance of the patient-family relationship and the part that plays in our ability to professionally self-regulate and be able to do our work with an autonomy and a philosophy of patient and staff-centeredness.
So How did getting this in place at Penn work? How did you bring these changes, and how did you make sure you had those essential elements as you were rolling this out?
Well, let me tell you the story. We went to our clinical chairs. We're an academic organization, and our physician organization is primarily employed physicians, although that's not exclusive, but certainly a majority in many of our hospitals. And we went to our clinical chairs with a proposal on how we were going to do our risk reduction and brought the Vanderbilt proposal for how we might work with them and how their system works. And we had some very interesting and intense conversations, but it was fascinating to watch the tide of how a few very key influencers in our clinical chairman group stood up and said, this is the right thing to do for many reasons, not only for our malpractice, but also for our brand, for our patient experience, and for our staff professionalism. So that was the first discussion that we had. Then we had another critical discussion, which was how do clinical chairs and leaders sort of back off some of these initial conversations and be willing to give those up to peer messengers and not necessarily know about them. And again, we had a couple of folks stand up and say, if this is what the Vanderbilt program recommends, then we need to try it and sort of have some faith that we can do this and we don't have to be involved with individual episodes of patient complaints or professionalism issues, and that we're willing to see peer messengers within the organization that are trained and our ability to be involved if that escalates and people don't improve. So in other words, it's really taking that leap of faith that they're willing to let their faculty improve on their own and not have to be aware of all of these individual episodes.
Can you tell me a little bit about how this work and this engagement that you've had thus far has impacted your ability to make change and really promote some of the change in your organization, and especially around, your work as the Chief Quality Officer? How has this professionalism structure helped move some of those changes forward?
I would say that courage, the role of the clinical leader in all of this, is essential, and the ability to be upfront, the willingness to talk about it, share. We have a very data-driven culture here, so the ability to work with Vanderbilt, who provides us with lots of really good data that compares us, both internally but also to very large groups and types of physicians in the same specialty. That has been an essential component of how this has survived and thrived in many ways. The other thing that working with a partner like Vanderbilt does is we then get the ability to be collaborators on research studies that clearly show the connection between malpractice, unprofessional behavior, and clinical quality, like surgical complications, like beginning to pick up inpatient complaints, early signs of potential cognitive issues. So these are all things that, in an academic organization in particular, are very, very appealing to the clinical leadership. And then, of course, you need to have the alignment with the administrative leadership, because if you prepare yourself for end arounds, if you're going to be doing interventions on very high-volume physicians who have a lot of stature in the organization, senior, then you have to be able to both be on the same page and understand where some of these challenges will come from and be able to have an aligned or a similar conversation with people.
So talking about challenges, what are some of the challenges you faced as you rolled this out? If you could sort of go back in time and find your younger self and say, what would you want to do to avoid maybe one of them?
So I think the first one is how important the front line is. And the challenges were getting people to step forward and say, I'm willing to be a messenger. I'm willing to be trained. This isn't something necessarily that frontline clinicians have thought about or are necessarily comfortable with. So getting that initial physicians who are willing to serve in this role and who are willing to be trained and, to go have some critical conversations with colleagues That is certainly something that takes a lot of discussions, a lot of reaching out, and understanding who key stakeholders are and who can influence, and how do we get people to describe this in a way that appeals to their own sense of professional accountability and how that impacts the organization.
Mm-hmm.
So that was one. The second one, I think, is really around understanding what it is that we're finding. If we identify a physician who's an outlier in patient complaints or professionalism events, that staff are reporting, what is it that's behind that activity? So, a lot of times when you have sort of a cluster, a small number, you look at that and say, okay, there's two sides to every story, and sometimes it doesn't require this huge investigation. On the other hand, when you really start to pick up patterns, you look at, so is this person, do they have their own behavioral issues, which may or may not be the case? What else is going on, either physically or emotionally in their life, that they carry with them to the clinical setting and are having difficulty separating? And then finally, is it the system in which they're working in terms of the support that they have, their own philosophy on how they schedule themselves and their activity? And then when you identify those potential issues, how do you help them get help when maybe, that's not something that they want to acknowledge or to consider? So that's the other one in terms of how does the organization respond. We train messengers to go out to deliver a message, but not to tell the physician they're meeting with what to do, per se, or say, I've got some advice, but also training the messengers how to understand that there are maybe other things going on that they can then be able to provide resources, what exists in the organization, to help them.
Great. Are there a couple of sort of key takeaways from your experience in doing this work that you would share with our audience who might be embarking on looking at professionalism?
The first is a willingness to take a long view, I think, is really important. I think that having a burning platform for us was our malpractice expense, which we, by the way, have reduced by 50%. But we've been working on this since 2006. So it takes a while, but we've seen that reduce, and we've seen our patient experience go up from sort of the lower half of the benchmark to top quartile and even top decile in a couple of cases. And then we've seen our risk-adjusted mortality go, top decile against national benchmarks. But our initial burning platform was really our malpractice expense. And I think from an organizational standpoint, you have to determine what that is. For many organizations, getting out of the box on this is hard, and so it really helps to have something that you can get people to rally around and agree on in terms of something that's really important for the organization. And then finally, I would say the data that we get from working with Vanderbilt is really critical. We send our patient complaints and we send our staff safety events around professionalism to them. So we take our own staff sort of out of the middle of some of those conversations so they don't feel like they're really ratting on a colleague. But that data, when Vanderbilt comes back with here's how you compare to X, Y, and Z colleagues at Penn and also nationally against your specialty, that has proven to be a very, very important aspect of the program.
It sounds like one of the key messages here is that, unfortunately, culture change is not easy. But if you keep at it and you really have the alignment and the dedication and the data to back it up, you really can make some changes.
Right. Again, one last thing I would say is, personally, I'm a big believer in peer-to-peer conversations at the front line as a way to just improve almost anything that you feel is really important, because being able to train messengers who work on the front line to have these crucial peer-to-peer conversations, and that could be doctors, nurses, respiratory therapists, but really is a way to get people moving on improvement by talking to each other. So I think that's a really critical aspect that I want to emphasize.
Couldn't agree more. Thank you for joining me today.
Thank you, and I appreciate the opportunity.
And for more information on resources from the AHA Physician Alliance, I encourage folks to visit www.aha.org/physicians. And we look forward to having you on the next one of our podcasts.
Okay.